Ladies and gentlemen, Dr. Dehnert, dear Victor, as you just heard, this is a pro and con session, so people are supposed to fight, and this is why I designed my presentation in the way so as to provoke an emotional outburst from the godfather of the Ross operation in Germany, Professor Sievers, who will speak right after me. So, aortic valve replacement, stay on the left side. Why does it have to be emphasized that you should operate on the left side of the heart if there is an issue with the left side of the heart? Because, as you all know, the Ross operation is an operation that tackles both sides of the heart. You take out the pulmonary valve, which is good and healthy, and you put it in place of the diseased aortic valve. And then in turn, you obviously have to replace the now missing pulmonary valve with something else. And the controversy is always why touch two valves, or I actually phrased it, why ruin two valves when only one is diseased. I replaced the ruin by touch to be a little less provocative, when only one valve is diseased. Well, these images here were kindly provided to me by Eugenie Riesenkampf, who you heard already speak this morning. This is an MRI of a little girl 2 years after the Ross operation. And the main thing you can see here, this is the pulmonary valve replacement, a homograph, which is dilated, and it is so dilated because the distal insertion is stenotic, so a failure of the right-sided graft already 2 years after the Ross operation. And also note the large size of the aortic root, which is still competent but clearly larger than normal. This is what we have been told the Ross operation is doing. This is just one example of many studies, follow-up studies on children after the Ross operation that do exist. This is freedom from reoperation on the autograft on the left side, which is perfect, at the cost of obviously a need for replacement of the artificial valve that we put in on the right side, the homograft or allograft or whatever you want to call it. So this is the theoretic concept, this is the ideal situation which has been achieved in that study. However, these authors also noted something else. This is here the size of the left side of the neo-aortic, of the autograft annulus. You can see here that it is increased in size substantially here from before the operation to follow up. Yeah? So there is an increase in size of the neo-aortic left-sided annulus, which is supposed to behave entirely normal. And other groups have quantified this development and reconfirmed it, that yes, indeed, in the majority of the patients after the Ross operation, the diameter of the autograft root, of the neo-aortic root, increases eventually in many of them, resulting obviously in regurgitation. And this is a more recent study here, which shows you the real situation as we see it nowadays. This is the frequency of reoperations on the right side, which is very little, and this is the need for reoperations on the left side. So in fact, there are centers, there are places where more patients after the Ross operation need redo surgery on the left side than on the right side, and this, I think, is something that we have learned quite recently. And this is another example given to me by Eugenie here, a patient who underwent the Ross operation in 1999, so 13 or 14 years ago, a grossly dilated neo-aortic root, which is heavily incompetent. I think one of these patients that you see here, this is another one, is going to be operated on Monday by Dr. Fotiadis. This is the same situation, a different patient, a grossly dilated aortic root after the Ross operation. There is another issue which I just briefly want to touch upon, and this is mortality. If you do the Ross operation in a neonate, there is a substantial mortality. Obviously, we see only data published by the brilliant surgeons who published the very good results. But if you look at the more objective databases, this here is the STS database, you can see here that there is clearly a substantial mortality of the Ross or Roscono operation done in neonates and infants. Here we talk about in-hospital mortality in the range of 20%. So this is not a simple operation, at least when it's done in a very small child. What is the alternative? The classic alternative is replacement with a mechanical valve. And again, traditionally, we have been taught that a Ross operation here called human valve replacement is always superior to a mechanical valve replacement, and this has been shown in a number of series. However, there's also other papers, such as this here, where they performed a more complex statistical analysis, and I think that Joachim also already alluded to this paper, where the incidence for redo surgery after the Ross operation has been shown to be clearly higher, the need for redo surgery after Ross clearly higher than after replacement with a mechanical valve. Well, the obvious issue, and there is no way to go around this, is the development of a too small prosthetic valve. If you put such a valve in a small child, the development of patient prosthesis mismatched, because obviously these valves do not grow, and there are very nice algorithms out there that have been published. For instance, here, if you observe an abnormally high gradient across an artificial valve in a younger patient, in a growing child, then you check for this and that, whether there is something clearly wrong with the valve, and if not, then you determine the actual opening surface area of this valve, and you quantify it in relation to the patient's body surface area. You calculate this ratio, and if this is less than 0.85, then people talk about a mild to moderate PPM, patient prosthesis mismatch, and if this is less than 0.65, then clearly the valve has become much too small and you should urgently do something about it. Well, this is obviously an issue which is also life-threatening, at least in some places. These data here clearly show that the survival with a small aortic valve with PPM is much worse than with a larger aortic valve. However, interestingly, this is not always the case. There's also other studies there from experienced physicians and surgeons that show that if you have a certain degree of PPM, it's not so bad. You can still live a more or less good life with that. And what about other places in the world? This is a paper that Professor Alexi kindly gave to me. This is a group from Africa. African surgeons, they simply put in mechanical valves into a lot of children with rheumatic and other forms of heart disease, and they are very happy with the survival and the freedom from reoperation. And you get the same kind of message from places like China, for instance, too, where people are happy to put in mechanical valves in children, and they say they do just well, although there is obviously this infrastructural complication induced by the need for anticoagulation. The other alternatives, well, Joachim already extensively covered the valve reconstruction surgery, so I skip all of this, and I just want to add something. He showed you the replacement of one valve with a pericardial leaflet, and the other valves were still the patient's only valve. We can take this a step further. This has been done for many, many years. This is a classic picture by Carlos Duran, but this technique has been perfected by Dr. Osaki in Japan, who treated more than 400 patients now with this way. He takes out the entire valve and replaces all three leaflets with autologous pericardial leaflets. This is what it looks like at the end. I even have a small video here given to me by my friend Scott Rankin, which I'm not going to show you for reasons of time. And Joachim also mentioned the issue of dilation of the aortic root after such a biologic replacement or reconstruction surgery. We are even tackling this here in Berlin. We're performing a trial together with colleagues in Munich and then elsewhere. This is one of these rings to support the aortic root that Joachim has not shown you. This is not implanted outside of the aorta. This actually goes below the valve within the aorta. This is how we do it. And there are plans of doing this, of combining this with a total autologous pericardial leaflet replacement of the entire valve, giving you at the end a total autologous biologic valve that cannot dilate any further because the annulus is more or less fixed. So, to come to an end, the Ross proponent's approach classically would be you have a child with aortic stenosis, you do a balloon valvuloplasty as Peter Ewert showed us, and when that doesn't work anymore, you do a neonatal or infancy early Ross, giving you, if you're not lucky, a high early mortality, a later aortic root dilation, and inevitably degeneration and the need for replacement of the right ventricular outflow tract graft. So I believe in the future, a more modern approach may be balloon valvuloplasty, which we will always use, then followed, once that fails, by an attempt of AV valve repair, which may last for some time, and then why not try it once again or do something like a total autologous pericardial valve replacement, which again gives us time until adulthood when we could then safely put in a nice and big mechanical valve, or do then eventually a Ross operation, but then with a stabilization of the root so that no failure can occur. Thank you very much.